Picture the moment healthcare AI finally arrives. A robot in a white coat, maybe, making diagnoses, replacing your doctor. Here's the thing. While we were watching for that, AI quietly moved in. Not as a doctor, but as an assistant. It's reading scans, drafting notes, scoring risks, reviewing claims, and answering your messages. Right now, in ordinary clinics. This is where AI already influences your healthcare. 5 places, 1 pattern, and what keeps a human answerable for every one of them. Health tech frontier. Start with the eyes. The FDA has authorized over 1,500 AI-enabled medical devices, about 3/4 of them in radiology. One whole class, called computer-aided triage, was built for speed. Software that reads new scans for signs of trouble, a stroke, a bleed, a clot, and alerts clinicians that a time-sensitive image is waiting. But read the regulation and notice what it can't do. It can't pull a case off the reading list, and it can't even mark a spot on your original scan. It notifies, it doesn't decide. The standard read still happens for every case. The AI just changes the order. Now the exam room. With your consent, an ambient scribe listens to your visit and drafts the clinical note within minutes. In one academic pilot, 46 clinicians at an academic health system, time in notes dropped 20%, and after-hours charting dropped by nearly a third. But the same pilot logged the failures, drafts that paraphrased medicine into lay terms, and long conversations shrunk to a sentence or two. So the drafts were treated as drafts. A clinician reviews and edits every one before it's signed. Keep that pattern in mind. You're going to see it again. Third, the predictions you never see. Hospital software scores things like your risk of getting sicker, quietly in the background of your chart. Since 2025, federal rules have pulled these tools into the light. Certified record systems must let the clinicians who use them see 31 facts about each predictive tool they ship. Its purpose, its limits, and how it was tested for fairness. Why does that transparency matter? Because predictions can fail, and one of the most famous failures in American healthcare shows exactly how. Sepsis is one of the deadliest emergencies in any hospital, and one of the hardest to catch early. So when a widely used record system shipped a sepsis prediction model, hundreds of hospitals turned it on. Then researchers at one academic medical center tested it against reality. 27,000 patients. At its alert threshold, the model missed about 2/3 of sepsis cases. And when it did fire, roughly 1 alert in 8 pointed at a patient who actually developed sepsis. Too many alarms aimed at the wrong patients. Researchers warned that's exactly how alerts get tuned out. The lesson isn't that prediction is useless, it's that predictions have to be checked before and after they ship. Fourth, the decisions about paying for care. Insurers use algorithms to help review coverage requests. And for Medicare Advantage plans, the government has drawn a line. An algorithm alone cannot be the basis for denying an admission or downgrading it to observation status. Your individual circumstances must be considered. And when a plan is about to say no on medical grounds, that decision must be reviewed by a physician or other qualified professional first. Assistance is allowed. Automating the medical no is not. If a denial ever feels automatic, that distinction is worth remembering and worth appealing. And fifth, the reply in your patient portal. At a growing number of clinics, when you message your doctor, an AI drafts the answer first. A human on your care team reviews it before it's sent. Used well, it buys clinicians time. But notice the pattern one more time. The machine drafts, a person decides. Every place we've visited runs on that same handshake. So what does meaningful oversight actually look like? You've already seen it. The triage tool that notifies but can't decide. The scribe draft that isn't real until a clinician signs it. The risk score that ships with 31 disclosed facts. The denial that legally requires human judgment. None of this is automatic safety. Reviews can be rushed, alerts can be ignored, rules can be broken. But it's the architecture. AI assists, humans stay accountable. When that handshake holds, you get the speed without surrendering the judgment. Which leaves the question this series keeps asking, the one question that covers every system we've met. Is AI part of my care? And who checks its work? Ask it at the imaging center. Ask it in the exam room. Ask it when the denial letter comes. Because the answer tells you whether the handshake is holding. And when AI gets it wrong, who catches it and what happens next? That's a full investigation of its own. It's coming on this channel. This has been Health Tech Frontier. Subscribe for the next chapter.